So current definition of asthma, and it's only current, it's highly suspect it's going to change. So it's a chronic disorder, and the implication when using the word asthma is that it's lifelong. And that's why there's sometimes hesitation by some authors to say that this is asthma in some groups, or for us to diagnose asthma, because we're kind of giving the patient a lifelong diagnosis. I don't necessarily agree with that, but that's kind of some people's approach. I think it's important to remember it's an inflammatory disorder and not necessarily an allergic or eosinophilic inflammation, but it is an inflammatory disorder. And it's characterised by respiratory symptoms such as wheeze and shortness of breath, plus variable airflow obstruction. And the variable bit's important because that's what separates it from COPD, which is kind of more fixed airflow obstruction. The main presenting symptom, or the symptom that we associate with asthma, is wheeze, which is unfortunate because we don't actually all agree what wheeze is. The formal definition of wheeze is it's a high-pitched musical or whistling sound produced by airflow through narrowed airways. And you get the noise because the airways are abnormally narrowed, so just like a musical instrument, you get vibration and that produces a musical note. But so you have to have some flow to actually get the noise, which is important when someone's got really bad asthma, because the flow drops off and the wheeze drops away. The wheeze can be acute or chronic, and it can be there all the time, in which case it's not asthma. And it can be monophonic, so one large airway, or it can be polyphonic, so you're hearing lots of different notes from different sized airways. And that's what we usually hear with asthma. But you have to think about all these things, particularly the monophonic versus polyphonic, when listening to decide, has this patient got asthma or have they got something else? Unfortunately, we don't always agree with parents about what the word wheeze means. So parents use wheeze for a variety of different noises. When played sounds of wheeze, only 59% of parents of children with wheeze can identify wheeze correctly. And the agreement between doctors and parents about what children have wheeze is less than 70%, which is quite concerning. And so parents are reporting a whole lot of different noises as wheeze. And there's a cultural component as well. In some languages, the word for wheeze is the same word as the word for cough. So they may not actually recognise there's a difference. I always ask parents, does your child wheeze? And then I ask them, what do you mean by the word wheeze? And if it's a young child, they almost never mean the same thing that I do. But I've kind of, having gone through that experience, I've broadened my definition of wheeze a bit, because young kids are sometimes a lot more rattly than whistly, and it's still airway narrowing. And that's where that whole concept that it's coming from a narrowed airway, so there's abnormalities about the way the child breathes and prolonged expiration, which are important as well. But the central message here is when parents use the word wheeze or asthma or any medical word, you've really got to check that they're meaning the same thing that you are. Asthma has pathophysiologic features, and I think when we think about asthma, and because the definition of asthma is changing and the concepts of asthma are changing, and it's because not all patients get all of these features. So in the past, there's been an assumption that all patients with asthma have eosinophilic inflammation and they have bronchoconstriction, and that's why they're wheezy. But patients may have different amounts of each of these features, so they will present differently in different ways. So firstly, there's airway narrowing, so there's smooth muscle constriction, but you can also have airway remodeling, with thickening of the airway basement membrane, so there's permanent change and permanent narrowing of those airways. A little bit like COPD, that there's permanent narrowing. There's an inflammatory infiltrate, and we usually think of that as eosinophilic, but that's only true in about half of asthmatics. The rest, and the thing is, when you look at the research, you've got high average eosinophil counts in the sputum of patients with asthma. That's because those who've got eosinophils in their sputum have so many. Whereas the others may have neutrophilic or other forms of inflammation. It's airway remodeling, there's airway edema contributing to narrowing. And the one thing we always forget because we don't have a good treatment for it, is mucus hypersecretion. So cough and productive cough and mucus is actually a symptom of asthma, but because we have bronchodilators, we think about it as airway narrowing. Also, I just want to emphasise that I see a lot of patients with chronic cough who don't have asthma, they have bronchiectasis. And so if a patient presents with chronic cough as their main symptom, you really, really have to think about other diagnoses and not asthma. So by mixing up the amount of each feature, we end up with different phenotypes or types of asthma. Do we need them? Because at the moment the treatment's not that different, but in the future we may have different treatments for different phenotypes. The prognosis is going to be different, and that's really important when we start talking about preschoolers with wheeze. And children may or may not be different from adults. At the moment we're saying they are, but in the future we may say they're the same. We're quite used to the idea of multiple phenotypes in adult asthma. We've been talking about this since the early 90s, when people recognised that if they looked at their individual patients instead of their averages, that some patients did not have eosinophilic asthma, that they had neutrophilic or paucigranular or mixed patterns of inflammation, and that those patients responded differently to inhaled steroids. So this is the current thinking on the types of asthma. So classically, the more eosinophilic inflammation you have as an adult, the more symptoms you have. And so you get this group here, which they've called concordant disease. So people with a little bit of inflammation, not many symptoms, increasing inflammation, increasing symptoms. And right up the top here are the patients who need to go to secondary care. But then these patients have non-eosinophilic inflammation, and there's this found a lot in obese female patients, but lots and lots of symptoms. And so they're quite difficult to manage. And these patients are a real worry. These patients have lots of inflammation when you take a sample, but they don't have many symptoms, and the concern is that they're getting progressive lung damage without realising it. So that's why they're highlighted as a different group. So these patients, you can titrate treatment to symptoms because you're going to treat the inflammation and the symptoms together. These patients, you're going to be treating the symptoms more than the inflammation, and these patients are going to be treating the inflammation more than the symptoms. But these are all adult patterns, but the paediatric respiratory specialists saw this and got really jealous, so we had to come up with our own thing for children. And what we started was separating children into preschool wheeze and school age wheeze, and the idea is that from school age into adulthood, it's all the same as adult asthma, which it's probably slightly different. And the reason for that is, going back into the 60s and 70s, we used to talk about wheezy bronchitis. Kids would have wheeze with a cold, and by the time they got to school, it would go away. And it's the same sort of idea. So 50% of preschoolers will have an episode of wheeze before they get to the age of 5, but only about a third of those will continue to have wheeze at school age. So that's why we don't want to call them asthma, because we might be giving them a lifelong diagnosis, starting them on lifelong treatment that they don't need, and 2/3 of them aren't going to have that disorder. Preschoolers respond differently to therapy than school-age kids, so it's important to separate them out. And the big question is which preschoolers will go on to have asthma. I don't think it matters, because I think the fundamental point is preschoolers respond differently to school-age kids, whether they go on to have asthma or not. But a lot of people are concerned that the preschoolers who go on to have asthma should start on asthma treatment really early. That's not borne out in the trials, but that's the concern. They're trying to prevent that fixed airway obstruction that comes from airway remodelling, which occurs very, very quickly, within about 6 months of the onset of symptoms. So here's our little boy. How do we know that this 2-year-old boy is going to become this school-age boy with asthma, and does it have anything to do with this cat? So to diagnose, this is the kind of BTS, British Thoracic Society approach to diagnosing asthma in children. Asthma is a clinical diagnosis in children, so it's based on symptoms, it's based on likelihood. Take the symptoms and say this patient has a low likelihood or a medium likelihood or a high likelihood of having asthma. We can do some testing, but it's only supportive, as opposed to the current approach in asthma, in adults, where you want to separate asthma from COPD, so you need to do spirometry. It just helps out in kids. And the thing that really defines it for us is how does the patient respond to therapy. That's going to tell us whether the patient has asthma or not. And every step of the way in each review, always considering this could be something else. Now, having said that, almost all kids with wheeze will have asthma and will respond to therapy, so it's quite straightforward. And what we're looking for is those who don't respond in the typical way. So helpful features, the specificity of symptoms. So wheeze with a cold and wheeze with dust and wheeze with exercise, as opposed to wheeze every single day no matter what's going on, or wet cough every day no matter what's going on. A history of hay fever or eczema is really helpful. A family history of asthma and eosinophils in the blood can be helpful. Unfortunately, there's a big overlap. So there's some various scoring systems where you can add up the little score for each item, and patients with asthma have a higher score than patients without asthma. But there is an overlap, so it's not actually discriminatory, and the accuracy, unfortunately, is only about 60%, which is a bit disappointing. But as I said, I don't think it matters because it's the age that's important. As far as we know right now, it's the age that's important to determining treatment. Things to really watch out for, red flags. The big one is wheeze or stridor every day. So a child who's got noisy breathing all the time has a congenital airway abnormality, not asthma, and they need referral for assessment. A daily wet or moist cough. So those kids probably have bronchiectasis and they need to be referred to your specialist for assessment. Likewise, children with failure to thrive, chest wall deformity, digital clubbing, they're likely to have some other chronic disease such as immune deficiency or cystic fibrosis, and they need to be referred for specialist assessment. And kids with recurrent skin abscesses or other infections also likely to have an immune deficiency, and they need to be assessed further for that. As I said before, diagnostic tests are not necessarily helpful in children. So most children with asthma, even those with severe asthma, will have normal spirometry when they're well. I do it in my clinic with all my asthma patients, but that's because they're never well, the ones that I see. You know, if you did it in your practice, you'd find that all your asthma patients generally had normal spirometry for the kids, except when they were sick. Bronchodilator response can be helpful, but all you're measuring there is does the patient respond to salbutamol, and some normal people will respond, and some patients with asthma will not respond and reach the cutoff threshold on that particular day. So I find it's more useful to ask the patient, do they feel better when they have their inhaler? Likewise, exercise challenge. About 20% of people without asthma will have bronchoconstriction with exercise, and about 20% of patients with asthma won't have bronchoconstriction with exercise. So again, not necessarily helpful, and similar stuff with the inhalational challenges, which we don't do actually in our practice, partly because they're dangerous and scary. But they're not as specific as you would like, and they're really research tools. And the problem is that most of the research is based on big population studies where you do this on 10,000 people, and there's an obvious difference, but when you get down to the individual patient, it's not that discriminatory.